Good afternoon, House. Good afternoon. Am I audible? Good afternoon, House.
Yes, good afternoon, Chief. You are audible.
You are audible.
Okay. All right. I want to welcome us to the first quarter CME of Taraba State Nma. It was actually built to start by 3 o'clock. It's 10 minutes past 3 now. I think we can start. We don't have to wait for everybody to be on board. The other people can join us, and there will also be a recording. So people that miss some parts, they can also hear from the recording. On behalf of the chairman, Nma Taraba, I welcome us to this virtual series for today. Tomorrow will be physical. So we have 2 presentations to make today, and tomorrow we also have another 2 presentations to make. So in order to make judicial use of our time, we will take the 2 presentations at the same time, then it will follow by questions. So if you have questions, you reserve it at the end of the 2 presentations, or you can put the questions on the chat box. We can also get from that. Then, as a way of question, we are all adults here. It will not be nice for us to be calling names in between the presentation. Please, everybody should ensure their appliances are mute so that we don't distract other people while the presentation is going on. So the first presentation for the day will be Scabies, which will be taken by one of our consultants from Federal Medical Center, Jalingo, by name Dr. Sally Chuwak, which is a consultant dermatologist. We are lucky to have dermatologists in the state, and this is an opportunity for some of us to get to know her, and it will also make us to know that we can refer patients to Federal Medical Center. So we'll give this opportunity to Dr. Sally Chuwak for her presentation. Over.
Thank you very much, moderator. I said listening to listening to this presentation. Taking out time. As the moderator initially said, I'm Sally Chuwak, working with the Federal Medical Center. So I welcome you all to this. Today we're going to be talking about, and I'm going to use outline. I'll introduce the topic, talk about the cause, the risk factors, different types, the life cycle of the organism. I'd also like to talk about the clinical features, complications, and how to diagnose. I would like to also talk about treatment and how to prevent, and tell us the World Health Organization for scabies. So as a way of introduction, scabies is one of the neglected tropical, and it has a very significant because the number of people that are infected yearly is very, very large. We have over 200 million at any time have this infection, and generally globally, every year 400 million suffer from scabies infestation. In the United States, it is said that 5% of all dermatology clinic visits are as a result of infection. And it's also that in the first 4 countries, like Nigeria, that most of the infections occurs in children, and it accounts for up to 5 to 6% of clinic visits involving children. Here in FMC Jalingo, based on clinic records over the past 10 months, for every 10 people, about 4 to 6 of them have a diagnosis of scabies. So next thing is to talk about the cause of scabies. Scabies is caused by an arthropod, also known as a mite. It's called, it's also known as the human mite because of the cause. Okay, it's caused by Sarcopenia. There are other species, okay, that can that infect other life forms, other mammals, but not humans. But the one that causes infestation humans. So it has it can be distinguished from other arthropods because it has 8 legs, that's 4 pairs of legs, and the gravid female is very small. It's not a microscopic organism, okay, but it is so small. The gravid female is about 0.3 millimeters diameter. The male is usually about half the size, okay? So most times it's difficult to see with our naked eyes, even though it's not exactly microscopic, but it can appear as a black dot on the skin. And the transmission is usually from person to person, intimate contact, okay? This is what it looks like. This is what the adults this mite looks like. You can see the 4 pairs of legs. Under the microscope, this is what it looks like. We can see the image of the eggs and the feet. Those are the things that we have for if we're going to investigate in the laboratory. So there are different risk factors, different things, different conditions that can make someone to have a predisposition to getting infestation with scabies, and usually it's crowded conditions like in nursing homes, like in hospitals, those in admission, in or children in boarding school, travelers, people who have to spend the night in hotel that's not very okay. Sometimes the mite could still be there and the tellers are not like changing the beddings before the next client comes in. So people who travel a lot and have to share beds with they are predisposed to having scabies. People with poor personal hygiene. Initially, I said that people can get scabies from person-to-person contact. People with multiple sexual partners are also predisposed. Termites are inanimate objects that, like beddings, the bed sheets, the kitchens in the homes. So if someone with scabies spends a significant amount of time on someone's on a particular termite, yes, the mite can actually be transferred if someone also comes in contact with those same tested termites. So the typical history is that children are the ones that if it is not a contact that leads infestation, usually the history is that if it's a small child, full age child, one that you home because normally play with themselves, have close contact with themselves. So a small child can get tested and bring it home. Maybe infect their mom, and then the mom infects other people in the house. So there are different types of scabies. You have the common or the classic scabies, and then there's the nodular scabies, and then there's the Norwegian scabies. So first of all, talk about common scabies or classical. The commonest type, that's the type that's seen almost 85 to 90%. Okay. So such people with the common scabies usually have about 10 to 15 adult mites, and they have fewer rashes than the other types of scabies. but it is usually very, very cheap. So this is just a picture illustrating someone with the hand of someone with common scabies. Okay, you can see the rashes around the digital webs. That's one of the favorite locations of the mites. Okay, so this is common scabies. This is just an illustration also to further show the predilection for the interdigital web for these mites. Nodular scabies is seen in about 7 to 10% of all cases, and it is characterized by the presence of nodules. Nodules are like lumps. They're lumps with diameter greater than 5 millimeters. Okay, and it's usually seen in babies and individuals who have disturbance of sensory perception, in people who cannot scratch, people who have diseases like leprosy. They usually have problem with perception. So nodular scabies is also common amongst them because they cannot scratch and they can't even mount an immune response that would lead to scratching. So the next type, the last type that we're going to talk about is the Norwegian scabies. Okay, this is the type that's also known as prostate scabies. That's usually seen in the immunocompromised people. That's people with HIV, people with severe malnutrition, people who have used steroids for a very long time, people with diabetes, or people who have mental illness. Okay, they are also unable to mount. These people are unable to mount an immune response that will lead to scratching. Okay, and for that reason, the mites continue to reproduce unabated, and the lesion is usually not very itchy because, as I said, these people are immunocompromised. So the lesions are usually widespread, they're usually dry and usually scaly, and it can lead to confusion with other skin diseases. For example, psoriasis may just look like it has, the Norwegian scabies can actually look like psoriasis, which we'll show pictures of later. So you can see this is the palm of someone with Norwegian. If you compare with the first picture that I showed about the classic scabies, you can see that the lesions are very florid. Palms, usually in normal people, in people who have a good immune system, the palms are not even usually affected. Usually it's the dorsum of the hands that is affected, and the interdigital web, where you can see someone here with region scabies, the palms are very, and the lesions are very florid. This is also the back of someone. This is the back of someone with region scabies. You can see the lesions are very close. They're very crusted. So this is someone with suppression. So we're going to talk briefly about the life cycle and the pathogenesis of mites. The rabbit female invades skin by creating what is known as a burrow. A burrow is usually a serpentinous or a linear elevation of the epidermis. That's the stratum corneum, which is the topmost layer of the skin. Okay, that stratum corneum is usually known as it's a dead layer. It's made of scaly cells. Okay. So this mite usually does not go into deeper layers of the skin. It just limits itself to the most superficial layer of the stratum corneum. Okay, so usually the adult female produces 2 to 3 eggs per day. And the life cycle of this, the average lifespan of a female scabies mite is 30 to 60 days. So within that 30 to 60 days, about 60 to 90 eggs are produced by a single female mite. Usually the males, you don't find the males in the burrow because the males usually die after mating. So usually it's just the female, the 10 to 15 mites that are usually found per person infested with scabies. is usually the female, adult females, because the males die after mating, and the female remains fertile for life once fertilized. So the lady eggs.
92 pounds. Why is it more expensive than last time?
The lady eggs and the nymphs mature within.
No, plus the drinks are inside. Drinks are inside.
The nymphs mature in about 2 weeks.
That's what you used to travel, Alexa.
That's 132,000 naira.
So where that one?
You can go on to first.
Okay. So this is train about that adult the adult might emerge from the burrow to the skin where the male and the female will meet. They will die and the female will mate the same person or a different. So this is just a diagram showing the life cycle, summary of life cycle, and how what the burrow looks like. You can see the adult mite here is invading. You can see how it invades the stratifornium of the next host, and then lays the eggs. The eggs mature and first of all the mold to larvae, and larvae molds to form a nymph, and this nymph molds also to become an adult mite. When the adult mite emerges from the burrow, they mate as saw in the previous slide, and then reflect the same person or the next person. So this is just a diagram showing the areas of predilection of the scabies mites. You can see it likes the axillary area, the inframammary area, the belt area, the love handle, the wrist, the ventral aspect of the wrist, and then the pubic area. So you can see this diagram. The other diagram here is the picture of the burrow. So this is just a further explanation, cross-section of the skin, what the burrow looks like on the cross-section. So the next is to talk about the clinical features of scabies infestation. Usually the first time someone is infested with scabies, the person usually is asymptomatic. That's because the symptoms of scabies are not really due to infestation itself. It's just a reaction to, it's a delayed reaction to the presence of the feces and the eggs and presence of mites in the burrow. So that explains why it takes about 4 to 6 weeks before 4 to 6 weeks after infestation before the person begins to show signs or symptoms of scabies. So we're talking about here in the immunocompetent individuals. Now, after that, after this time frame of 4 to 6 weeks, there's usually release of inflammatory mediators. These inflammatory mediators would usually now be responsible for the extreme pruritus and the rashes that are usually seen in scabies. So, but subsequent infestations, if, for example, someone has had an initial infestation, treated and got better, the next infestation will lead to an immediate reaction because the person has sensitized. So there won't be this delay again. The person will just immediately have symptoms of scabies like then the rash. So usually scratching would lead to inoculation of bacteria because the itching is very severe. And for those who do not trim their nails, in most cases, the skin barrier is reached, and that reaching of the skin barrier leads to inoculation with bacteria, and the commonest bacteria that are usually implicated are the Streptococcus species and the Staphylococcus. Okay, This can lead to complications like abscess formation, especially if it's still localized. But in rare cases, there could be invasive bacteremia with septicemia as a complication. And this septicemia can lead to acute injury, okay? And this accounts for about 10% of some areas, especially in the endemic areas. And it's also known to predispose this bacterial infection, okay, that can occur in people with scabies can actually lead to rheumatic heart disease in the future. So this next slide shows the a flow chart of the possible complications that can arise as a result of scabies infestation. Usually, the first thing is the itch scratch cycle that occurs as a result of that, the reactions, the presence of the mites, the eggs, and its feces. This leads to a disturbance of sleep. And if people are not able to sleep well, the next day they will not be very useful. And that has a very huge economic impact on affected individuals and their community at large. If the person is immunocompromised, there could be prostate, very big risk other people around, because prostate scabies is more likely to transfer to people, as the infestation is more likely to be transferred to people who come in contact with the person who has it. Now, the other complication, as I mentioned earlier, is infection with bacteria like Streptococcus pyogenes or Staphylococcus aureus, leading to skin sores known as impetigo. Impetigo just appears as boils. We have pictures to show later. It's commonly seen in children, and impetigo can lead to, as I said, invasion. It could lead to invasive bacteremia, which can lead to which can lead to chronic, or it can lead, first of all, it can lead to chronic, acute glomerular nephritis, which can later on lead to chronic kidney disease. And also, it may also cause rheumatic fever because of the bacteria that are. So this is a picture of a child who initially had scabies. You can see the typical locations, interdigital web, but it has become secondarily infected with bacteria. So this is impetigo in a child. Another picture of a child with scabies and impetigo. This is impetigo of the smaller rashes. You can see there are the scabies rashes, but the central one, there's a remark there, it's the impetigo. So the next thing is how to diagnose scabies. It is actually very easy to diagnose. If you take a very good clinic, if you take a very good history and you're able to recognize the typical pattern, it's like in the other slides that we showed, the typical areas that scabies likes to stay. If we're able to recognize that and take a very good history, we should be able to make a diagnosis of scabies without even further laboratory investigation. So there's usually a history of severe generalized body itching, which is present all the time, but it's usually worse at night or after taking a shower. There's usually if you examine, you would see burrows, which I said could be serpiginous, or they could be linear elevations, okay, of the epidermis. They could appear as papules. Papules are just raised lesions that are less than 0.5 centimeters in diameter. They could contain pus, which will now be called, they will be called pustules. If they contain just they are larger than 0.5 centimeters, then they are nodules. So these are the typical lesions that are seen. And usually from the history, you find out that not just one person that itching. Usually the entire family, if you ask them, you find out that the entire family be complaining of generalized body itching that has not been there since birth, okay? Usually the family members know the person that first started itching before others also began to itch. So if you just ask, they will be able to let you know. So these are the typical places. Again, I just for the repetition's sake, in the immunocompetent usually can be found in the ventral aspect of the wrist, the upper limbs, the axilla, the buttocks, the penis in men, the areola in women, and the belt area. Okay, but in children, the lesions are not usually this specific. In children, the lesions are usually widespread, okay? And usually in adults, you will not see the lesions on the scalp, but in children, yes, the face can be affected in the scalp, the palms, and the soles can also be affected. So this is another picture just showing you the digital web. And then this is scabies affecting the buttocks, and this also has a secondary bacterial infection. This is a pustule in a child. So this is what it looks like on the penis. The lesion on the penis doesn't usually look like what is seen on the other parts of the body, because here the area is moist, so the lesion here is not really it's not usually dry or skin. Usually looks more like a wheel. So this slide here on Scabies mangae, it just tells us, to remind us that yes, if we have pets at home, they could actually be infested with scabies, but this scabies is species specific. So Scabies is usually seen in cats, dogs, pigs. Okay, so if you have cats and dogs, and they happen to be infested with that particular species, yes, the human beings can actually be infested, but it doesn't usually lead to significant infestation in human beings, because the Scabies mangae cannot reproduce on human skin. So it just causes irritation, but it doesn't really cause an infestation. So how to diagnose scabies in non-endemic areas? Usually the history and examination can give out the diagnosis, but sometimes there'll be need to take a sample of the suspected burrow using a clear tape that the tape is pressed down on the lesion and then is taken to a microscope and viewed under the microscope. The presence of the mite, eggs, or feces usually would lead to a diagnosis of scabies. Sometimes the mite might not be seen, but the eggs or the feces might be seen. Sometimes dermatoscopic examination can be done. A dermatoscope is like a hand, like a hand lens, but it has a better magnification. So it helps to just identify this organism while it's still on the skin. So the next is the treatment. There's several treatments. Historically, scabies has been treated with permethrin, malathion, lindane, and protamethrin and sulfur. But over the past 2 decades, there has been a lot of resistance to the agents I just mentioned. There's a lot of resistance. Just the first few agents that I mentioned, it's usually a 50-50 chance of treatment success. But the last 2 treatments, the topical benzyl benzoate and ivermectin, oral ivermectin, are the treatment of choice nowadays. So these are just slides showing the different treatments. Okay, so the first effective treatment I want to talk about is topical benzyl benzoates. Now, everybody can use this. There's no contraindication to the use of topical benzoates. In the immunocompetent individuals, you give the patient instruction to apply the topical agent from the neck down to the toe. Every aspect of the body, from the neck down to the toes. And the treatment is usually applied at night for 3 nights. And we have to ensure that the topical preparation stays on the skin for a minimum of 8 hours. Can be longer than that, but then it can be washed. So it's usually applied at night and then washed off in the morning. So this particular treatment can only kill the larva, the nymph, and the adults. It does not kill the eggs. For that reason, we have to pause the treatment for 3 nights. After 3 nights of treatment, you have to pause treatment for 3 nights because you now give, if you remember the life cycle, it was stated that the eggs usually hatch after 2 to 3 days. So you give them, you give an allowance for them to hatch, and then you go back and start treating for another 3 nights. But for babies, I mentioned earlier on that the rashes are usually more extensive and usually can affect the scalp. So all over their body, this particular agent, this benzoate, should be applied all over their body from head to toe. The next highly effective treatment is oral ivermectin. Ivermectin is a very effective treatment for scabies, but it's contraindicated in pregnant women and children less than 15 kg of weight. So the dose is usually 200 micrograms per kg. Usually, 2 doses are usually given 1 week apart. So for a 60 kg adults, usually 12 milligrams is okay. So you give them 12 milligrams first day, and then 1 week later, you give them another 12 milligrams. So if we treat scabies with just the pharmacotherapy without talking about the non-pharmacological treatments, the patient will get reinfested by the organisms on their beds or in their cushion. So usually when you're treating scabies, you don't treat just the index patient, you treat all close contacts in the house or all their sexual contacts. A lot of patients I've seen also got the infection from home, especially first men who have to spend the night outside their homes, and usually they would need to be treated along with their colleagues. Okay, so the fomites should be fumigated, the beddings and clothes should be washed and dried under the sun, usually from morning to evening. And then hot iron can also be applied to these beddings and the clothes. It's also recommended that the beds, the mattresses, the chairs, non-plastic chairs in the house should also be either exposed to the sun for about 8 hours, or you could also use permethrin spray for those items. So it's important to note that despite the fact that these treatments are very effective, the treatments are very effective, and the patient is usually non-infectious within 24 hours of commencing treatment, the itching still continues. A lot of clients will come and say, oh, the rashes have gone, but the itching is still there. So yes, we have to explain to the patient that the itching usually does not go immediately. It usually does not go immediately. It takes about 4 to 8 weeks before the itching goes completely. So it's important to prescribe antihistamines. Okay, and for those who have complications, who have bacterial infections, who have the hepatitis, they should be treated with antibiotics. Okay, if it's a local infection, you could treat with mupirocin, a typical antibiotic, or if you suspect that it's becoming systemic, or if the bacterial infection is extensive, or you think it's very invasive, then you can use oral antibiotics like cephaloxime, like augmentin, even doxycycline can treat it. So because of the complications of the renal and the cardiac complications I mentioned earlier, usually for glomerulonephritis that is as a result of skin infection, it usually takes about 6 weeks for it to start manifesting. Okay, so it's good to give these patients, any patient that has been treated for scabies should be given a 4 to 6 week appointment with the intention of screening for renal disease. Usually the patient might have hypertension, might have blood in the urine. They could also have edema. So it's good for them to come back 4 to 6 later for them to be checked, followed up to be sure that they don't have this complication. So the WHO has certain recommendations concerning scabies. Okay, they recommended that scabies has been included as one of the neglected tropical diseases, and is recommended that by 2020 that all member countries should incorporate scabies management into their universal health care coverage package. So in Nigeria, we have the NHIS or the NHIA. It is recommended that it's recommended that scabies management should be incorporated to the NHIS. And one of the ways of preventing the scabies is mass drug administration. So it is recommended that in endemic areas like here in Taraba State, Nigeria, that it is encouraged that we should start with mass drug administration, and then ivermectin has been included in the essential drug list for scabies. So it is also important that NHIS should also follow suit and include ivermectin and possibly benzyl benzoate. So there are different differential diagnoses. One of the reasons why scabies is so common is because of misdiagnosis or difficulty in identifying scabies. So it can look like any of these diseases here on this list. So I'll just talk about them briefly. This is atopic dermatitis. In light skin, it appears as an area of erythema, usually very itchy, but you can see there are no papules. It's just a flat lesion with skin discoloration. It's usually wet and not dry. In dark skin, this is what it looks like. This is what atopic dermatitis would look like. It's something that the history would usually show that they have been having this issue since childhood, before they even went to primary school. They've been having recurrence of this. Is a child with atopic dermatitis. This is nipple eczema. Now, if you remember, I said that nipple is one of the areas that scabies likes to infest, but usually in eczema, it's usually not dry, it's usually a bit wet, okay? You can see this, we don't have any papules, we don't have any scaly lesions here, so this is nipple eczema. This is discoid eczema. It's a well-circumcised area of oval lesion, okay? And it's not scaly, so this is discoid eczema. This is psoriasis, chronic plaque psoriasis, okay? It's well-demarcated area, okay? This is an autoimmune disease. It's not as itchy. It's not as itchy as scabies. And you can see here we have plaques, not papules. This is nickel dermatitis in the belt area, but you can see there are no papules here. Okay. This is also nickel dermatitis from wearing of watch. This is photodermatitis. You can see that the area that is sun affected, that is sun exposed, area that shows erythema. Okay. This is another case of photodermatitis. In dark skin, it will appear as hyperpigmentation. Okay, I would like to thank you for creating time to listen. Thank you.
Hello? Am I audible?
Yes.
Okay. Yes, we want to thank Dr. Sally for this lucid presentation. The presentation is quite enlightening. And I want to believe with this presentation, the proportion of the scabies you are going to see in your clinic will reduce, so that you have time to attend to other serious diseases. So without waste of time, we will go to the second presentation. But before we go to the second presentation, I want to acknowledge some of our elders that have been with us here. I want to acknowledge the presence of Dr. Ebenezer Apake, who is retired, but not tired, a retired permanent secretary with the state. He has actually been showing us leadership, and he continues to show leadership. even in after retirement. We also want to acknowledge the presence of Dr. Alex Miangwa, the Chief Medical Director of Taraba State Specialist Hospital. We want to appreciate you for being on the call. Presence of people like you at least encourages a lot of us. So, is the second presenter ready? Dr. Bright. So just to inform us too, that we need to pay for the CME. It is with this payment that support us in organizing this and also supporting the presenters. So I will encourage us, the account number is on our blog. Please, let's try and pay the token so that this ministry will continue to remain on board. Dr. Bright. Dr. Bright.
Yes, sir.
The second presenter.
Yes, sir. Coming up shortly, sir.
Okay. So the second presentation will be taken by Dr. Gideon Akafa, who is a consultant anesthesiologist with the Taraba State Specialist Hospital. We all know that oxygen saturation is now the 5th vital sign. And the tool we use in assessing this vital sign is actually the pulse oximeter. So he's going to tell us about the principle and use of pulse oximeter that we use to actually assess this 5th vital sign that we are supposed to be taking routinely.
News dey for carry again you.
Over to you, Dr. Akafa.
Okay, good evening. Can you hear me? Can you hear me? Thank you very much. The excuse of the Nma Taraba for I'll be presenting the topic, principle of and uses of pulse oximeter. So just as the moderator has said, pulse oximeter is very important in our days in clinical practice, especially in the era of COVID-19. So we'll be presenting, following the format above, introduction, principle of pulse oximetry, potential source of error and limitation, and so on. So by way of introduction, the pulse oximeter is an instrument designed to measure oxygen saturation of hemoglobin blood. Oxygen saturation is defined as the ratio of oxygen content of hemoglobin over oxygen carrying capacity. And just as we said earlier, the pulse oximeter is the 5th vital sign considered by some authority. The coronavirus disease pandemic has caused an increase in the use of pulse oximeter. So what is the principle by which this pulse oximeter acts? The pulse oximeter operates on the principle of light absorption. That is using the Beer-Lambert law which states that there is a linear relationship between the concentration and the absorbance of the solution, which enables the concentration of the solution to be calculated by measuring its absorbance. So we see that the pulse oximeter operates based on two principles: the presence of pulsatile signal generated by arterial blood, which is relatively independent of non-pulsatile arterial blood, venous and capillary blood. The fact that the oxyhemoglobin and deoxyhemoglobin have different absorption spectra. So these are the basis on which the pulse oximeter acts. So currently available pulse oximeter use two light emitting diodes that emit light as the red light 660 nanometer and the infrared light at 940 nanometer wavelength. In the red region, oxyhemoglobin absorbs less light than the oxyhemoglobin, while it is reversed at the infrared region. At 800 nanometer, the isobestic point, absorption is equal. So the ratio of absorbency at these two wavelengths is calibrated empirically against direct measurement of arterial blood oxygenation in volunteers. And this is what is recorded in the pulse oximeter that will give you the reading. And the resulting calibration algorithm is stored in a digital microprocessor within the pulse oximeter. So during subsequent use, the calibration curve is used to generate the pulse oximeter estimation of arterial blood saturation. There are potential sources of error or limitation of the pulse oximeter as we use. If you don't know it, you may misinterpret the reading, the pulse oximeter. Just as we have said, pulse oximeter is very common now in the walls and everywhere. And you may need it to make a quick diagnosis, that you must know that there are limitations with the pulse oximeter. Number one, the shape of the oxygen dissociation curve. The partial pressure of oxygen less accurate at less than 80%. So if you look at the oxygen dissociated curve, which I'm going to see shortly, you will know that once it is less than 80%, it's less accurate. And we can see that carboxyhemoglobin affects the reading. It's going to give you a falsely high result. The carboxyhemoglobin and the oxyhemoglobin absorb at 660 nanometers equally. So because of that, difficult for the pulse oximeter to differentiate carboxyhemoglobin from oxyhemoglobin. And also the methemoglobin. Absorption of methemoglobin and oxyhemoglobin are the same, both at the infra and the red absorption. So when it is higher than 85%, the oxygen saturation, it will give you a false, lower result. And when it is lower than 85, it was high result. Also, anemia is one of the things that affect dye, nail polish, ambient light, false alarm, and motion artifact. We're going to see how they affect it subsequently. So this is the oxyhemoglobin curve. You can see that decreased temperature, decreased 2,3-diphosphoglycerate, and decreased hydrogen ion because it lacks heat. While reduced affinity will cause, increased temperature, increased 3-diphosphoglycerate, and increase in hydrogen ion will cause the right shift. The right shift means it's reduced oxygen, and then oxygen is then released. So if you look at the curve, you can see that the curve tends to be symmetrical from, if you look at it, from hundreds to 80. Once it goes below 80, that the curve becomes steeper, telling you that at that point, the result cannot be relied upon. So we are still talking about the limitation. We say low perfusion states. You know that the pulse oximeter use the pulsatile, a kind of artery to give you an accurate reading. So when there is low perfusion, it's going to affect the reading or the authenticity of the result. And also when there is hypothermia, when the extremity is cool, the result is giving you not really low, lower than what the result is. When the extremity is cool, all you need to do is to warm up the and reattach pulse oximeter, or you can even position of the pulse oximeter. Skin pigment affects pulse oximeter reading. In this part of see that some culture normally put decorations in their finger. So you have to check, see that this is not there. Or when it's applying all the fingers and you to apply a pulse oximeter, you have to use a razor to scrape it off so that you can get correct result. So research has suggested that pulse oximeter is not reliable in dark skin color, and so they marks the diagnosis of hypoxia in dark skin color. I think the fact that the calibration or was done in white is what is accounted for. So one should therefore interpret pulse oximeter reading in light of clinical symptoms and look at the trend rather than just a singular reading. That is what the take-home point I want to. Pulse oximeter does not dictate rest. That is, now we are looking at problems. What are the short for pulse oximeter? It does not dictate. What we mean by that is that the fact that it's telling you that this person has oxygen saturation of 100%, it doesn't mean that all is well oxygen. Taking in of oxygen and breathing out of oxygen. For everything normal, the person has to breathe in oxygen, and then cells is able to produce carbon dioxide enough and to tell it. But the pulse oximeter does look at oxygenation. It's not looking at ventilation, production, and expression. It's not looking at that exposure. So it's only looking at what? Oxygenation. And then if you have somebody that is accumulating CO2, you know that is a form of respiratory failure. So you have to look at other things also to boost the effects of the pulse oximeter. In very anemic patients, partial pressure of oxygen reading may show high saturation, although oxygen delivery to the tissue. This is very important for us to know that the pulse oximeter measures the percentage of oxygen that is bound hemoglobin. So, but in anemic patient, what happens? Maybe there is reduced hemoglobin. Okay, the pulse oximeter does not mention the hemoglobin blood. It only mentions the percentage of oxygen that is bound to hemoglobin, that is not bound. So the fact that somebody has anemia, that person may develop tissue hypoxia, but the pulse oximeter reading is 100% because the remaining hemoglobin or the reduced hemoglobin will be bound to oxygen. So while somebody is anemic, you should know that this person still needs oxygen. And that is why in anemic patients, see that oxygen administration is indicated, despite the fact that pulse oximeter reading is 100%. So let's look at the unique feature of pulse oximeter. One, what makes pulse oximeter very unique is that it's non-invasive. Unlike the others that you have to take blood, arterial blood, and whatever to go to the lab And here is very non-invasive. Just attach it to a figure, and that's all. Very portable. You can move it from patient to patient. We have different types. We have the handheld, we have the table type, the one we use in theater, and we have the finger tip type, very small. So it's very portable. You can move it from side to side, from place to place. Simple to use and to explain to laymen. Does not require warm-up time. It's cost-effective. It's cheaper than arterial blood gas and capnography. It's independent of gas and depot. It has a very fast response time. You can use it continuously. It also has what we call tone modulation. This tone modulation means it has some sound changes that, the sound changes. When the pulse oximeter is dropping, that begins to become harsh. In fact, if you get used to that tone, so you can even estimate what the pulse oximeter is. Has been a source of help to anesthetists and to other people that use it, because you know that you have many things doing. You can't just sit there at the monitor. Despite the fact you are far from the patient, if you start dropping, you see that the frequency of the and the tone start becoming harsh. So this can even call you, alert you from wherever you are to come and attend to the patient. We have a variety of probes that you can use, a variety of places that you can attach it to. And attach it to the figure, even if you need, and you have probe that will fit you. You have probe that you can fit the thumb and wherever you want to put it. There are variety of probes that you can use. So it's also battery operated in Africa. Our life cannot be relied upon. So uses of pulse oximeter. Just as we said, the onset of COVID-19, pulse oximeter, the usefulness came more to us, and we're so many places. So it has a wide variety of uses. Anywhere you want to monitor the oxygen, you have to apply a pulse oximeter. The WHO said it's minimum requirement of monitoring for any patient can have. Very useful in variety of cases. So monitoring of patients in each department, operative monitoring of patients in theater, monitoring intensive care, patient transport, during cardiopulmonary resuscitation, you need a pulse oximeter. In radiological procedures, in neonatal intensive care, and in fetal maternal monitoring in labor ward, to study the severity of obstructive sleep apnea syndrome, and in early diagnosis of silent hypoxia, COVID-19. And so in other, other varieties of uses that are not mentioned here. So you can see that, look at variety of cases, which of them can we use pulse oximeter? In disconnection, when you have a patient attached to maybe breathing cycle, and then there is leakage, there is connection of your either endotracheal tube or any of your tube, see that the pulse oximeter will quickly alert you. What will it show you? That the oxygen saturation is dropping. In a patient that is hypoventilating, pulse oximeter is a useful tool in diagnosing that, because it will show you that the SpO2 is dropping. In esophageal intubation, is very, very important here. Pulse oximeter in diagnosing esophageal intubation. For those that work in the theater, surgeons and whatever, so when you want to do general anesthesia, you have to paralyze this patient and intubate the patient. And through this endotracheal tube, you are going to give oxygen. And we know that the esophagus and the trachea are closely related. And during laryngoscopy, there is that probability of putting your tube, the esophagus, especially in patients that have difficult airways. And when the tube is esophagus, you will be ventilating the esophagus instead of water. And we know that within 3 to 8 minutes, you can have permanent brain death. So the pulse oximeter is very useful When it is in the esophagus, the oxygen saturation will fall, telling you that you are not in the airway. And so it is very important saving patients' life in anesthetized patients. It's also used to diagnosing bronchial intubation. We know that we have a trachea divided into two bronchi, the right and the left, where you want to put your tube in the trachea. But sometimes your endotracheal tube can go down one of the bronchos, either the right or the left, but especially the right, which is more horizontal than, so it may likely be right. And because of that, instead of you to be in the one lung will not be ventilated. And so this patient may have hypoxia during surgery. And so the hospital very useful to show you that decrease what in post-hospital in the oxygen saturation, which will point to the fact that your tube is not on the right, place. You have to shift it backward to the trachea. In hydrocarbon overdose, where the pulse oximeter cannot be used in that. In hypoventilation, yes, the pulse oximeter can be used. Hypoventilation, so you SpO2. In pneumothorax, yes, it will be useful in that. So you air embolism pulse oximeter will be used. There will be drop in SpO2. In aspiration, show you. In hyperthermia, if you not, you need the thermometer to give you that. Acid-base imbalance not help with that. Need another thing that will help you to a feed to be able to know that, or arterial blood gas. In cardiac dysrhythmia, of course, we need an ECG here. And in IV drug overdose, the pulse oximeter very helpful in that condition. So we are bringing it to show you that in variety of clinical scenarios, pulse oximeter will be helpful. So just as we see, you see that the pulse oximeter, you can use it in situation 1, 2, 3, 4, 5, 8, 9, and 11, just as we have mentioned. So sites of measurement. What are the sites you can put your probe to get a pulse oximeter read? You can put it in the finger. You can use it to in children. You can use the earlobe. You can use the nose in neonates. You can use the cheek. It can also be modified, non-invasive brain oximeter sensor on the forehead can be used that. So this is a slide that shows where you can use them. Look at the neonate, you can tie it around the foot. You can see it in the earlobes and other places. So I have just a clinical scenario that I want to present, just to steer of our thinking to see how what we have learned in the course of this presentation. You are called to the emergency room to evaluate the airway of a patient found unconscious after failed suicide attempt. He was found in his garage with his car running. His pulse oximetry reading is 97. He is very somnolent. You determine that the patient needs to be intubated. The medical student standing nearby want to know why you will intubate him if his oxygenation is normal. So this is a Zoom meeting. If it were maybe in the open, we'll have just say, okay, let's see how 1 or 2 people can give an input, but I'll be taking that input centrally here. We should know that in carbon monoxide poisoning, just as we have said earlier, we said the pulse oximeter cannot differentiate between carboxyhemoglobin and oxyhemoglobin. So the pulse oximeter will be reading the carboxyhemoglobin as oxyhemoglobin. And so to show you 100%, the 8 to 100, everything is well, there is no problem. Of course, we know that the carboxyhemoglobin has 250 times affinity for hemoglobin compared to oxyhemoglobin. So that patient may be dying severely hypoxic. The pulse oximeter reading is showing 7%. So you should know that this accident takes a close enclosed area and there is smoke or and this patient is exposed to that, and that was what makes him somnolent. So we should know that this is treated with what? With oxygen. So let me read what I have here. We said, despite a normal pulse oximetry reading, one must assume that the true arterial oxygen saturation is likely what? Low. That is the assumption you must make. And I will assure you that your assumption will be true. An arterial blood gas should be sent for immediately for co-oximeter reading. This will give you the true level of oxyhemoglobin and carboxyhemoglobin. Okay, so sorry. Not only that, the falsely high pulse oximeter reading is deceptive, and the patient, and it will mask hypoxia, just as I've said. Carboxyhemoglobin is treated with what? Oxygen. One of the cases, hyperbaric oxygen to treat. And also, we said that the patient is somnolent. The patient cannot be able to maintain his airway. So, in that case, the patient may need to intubated so that you can adequately treat it, oxygen, 100% oxygen. We have a scenario 2 here. A simple young lady of 20 years was rushed to accident and emergency unit, having collapsed while dancing in the party. She had earlier complained of abdominal pain, dizziness, and spotting. On examination, she is pale, hypotensive, with altered level of consciousness. Abdominal ultrasound scan was sent for, and it came out with the sonographer. It's a right ovarian cyst. And the report also showed that the uterus was noted to be bulky, but empty on the scan. Random blood sugar was within normal limits. What is the likely diagnosis? So, here, from the history, you can see that this lady has spotting, dizziness, and abdominal pain. She's a long lady that I always go to party. See that the party. So at that age, sexually active, and she collapsed. So likely, I will be thinking of ectopic pregnancy. So now say, what investigation will to confirm your diagnosis? You want to do a PT. I want to say here that our medical doctors are rapidly losing their clinical skills. Many times, we will just wait for the radiologist to give us what? A diagnosis. And that is what you are going to take and follow. You are forgetting clinical history, the examination you do, and of course, we know what is happening in the radiology department. If I start radiology residency, I will be the first on call. And of course, I don't have enough doctors. I will be left alone, and I must work. And of course, inexperience can be there, and so somebody not experienced can just telling you that this is a right ovarian cyst. And instead of you to use your clinical acumen, you will just carry whatever the grapher or sonographer said. And before you know, if he has not taken you. So we should stop treating lab investigation, and just as it has been handed over to us, and treat the patient the way the patient presents. Of course, these days we know that sonographers are fighting radiologists, and in many hospitals it's sonographers, and they are not well experienced. And so, even in the experienced hands, mistakes can happen. Sometimes you can be on call, you are the only one, you are fatigued. So you can, make mistake once in a while. So we are bringing this because things like this have happened before. So don't throw your clinical acumen away. Look at the patient holistically and manage that patient holistically. And so you will not lose a patient because of wrong investigation. So we also see that the third question says, explain why she collapsed. Explain why she collapsed. In ectopic pregnancy, when it ruptures, the blood will be collected, and so when blood is collected in the peritoneum, this patient will not be able to pump blood to the CNS. When the patient is standing, the patient will develop what we call orthostatic hypotension, and the patient has to collapse, and so that blood can reach the brain. So that is why this collapse. Many times when you see patient collapse in the scene, in theater, in whatever, as the patient is collapsing, want to collapse, many people want to come and hold this patient. Let's hold him so that he will not collapse. I want to say that this thing is very risky. All you have to do in that condition is to help the person to lie down. So the person is collapsing because of orthostatic hypotension. And this is a mechanism that will help the patient get blood to the brain. When you lie this patient flat, with that low blood pressure, blood can get because it has overcome gravity. So when somebody wants to collapse, don't hold him standing. Allow him, just help him lie down flat so that blood can reach the brain, and don't be in a hurry to raise him up. So what will likely be her SpO2? And this is what we have presented. I know many people want to say, the SpO2 will reduce. No, we said that the pulse oximeter measured the saturation of oxygen bound to hemoglobin. It doesn't measure the level of hemoglobin. So you will see that this patient will have 100% oxygen. And you shouldn't forget, that this patient suffering hypoxia, there's poor tissue perfusion, despite the fact that it has one SpO2 of 100%, because hemoglobin is not adequate. And that is why in anemia, give oxygen, despite the fact the oxygen reading, pulse oximeter reading normal. And the last question is, what will be your initial or immediate treatment? Of course, we know this is fluid resuscitation, grouping, and cross-match before your blood will come and before you take the patient to theater. So in summary, the pulse oximeter is a valuable tool patient monitoring. And when used correctly, it is quite effective in diagnosing hypoxemia in variety of clinical settings. It is therefore the singular most important patient monitor and the minimum standard of monitoring according to WHO. The pulse oximeter should therefore be available for use in all wards at all times. Thank you for listening.
Hello? Hello, am I audible?
Yes, you are.
Okay. All right. Thank you, Dr. Akafa, for your presentation. It's actually quite enlightening. So we will go straight to the session of questions and answer. But before we go to that session, I just want to acknowledge one or two of our elders who are on the call here. We want to acknowledge the presence of Dr. Hamidu Kara, the Permanent Secretary of the Health Service Management Board. Also Dr. Dashe with the Taraba State Specialist Hospital. So in order for us to be organized, let's use our handle, our app, and raise our hands so that we'll be able to identify people that have questions for them to give them the opportunity. But before the people raise their hand, there are some questions that are put on the chat, which I will read them the way they are being asked. There are 3 questions that were put on the chat. The first 2 goes to Dr. Ali, the dermatologist. The first question is, why not give the benzyl benzoate continuously for 10 days instead of breaking it in between? Then the second question to you is, how do we differentiate the lesions, other lesions in the genital area from scabies? Then for the second presenter, what is the normal SpO2, especially in pregnancy? That is, what is the cutoff range for normal SpO2, especially in pregnancy? So these are the questions on the chat. So please, if we have a question, let's raise our hand so that we can identify the people that want to ask questions. But in order to wait for those people, maybe we'll give this opportunity to Dr. Sally Chuwak to respond to the 2 questions that was being directed to her. Dr. Sally.
Yes, thank you very much, Moderator. Okay, so we're just trying to, that can actually that pause, we pause with that kind of like nice.
Doc, you are really, the network is really cracking. I don't know if people can change position a little bit. It's cracking.
Okay. Yes, can you hear me?
Yes, we can hear you.
Okay, so I was answering the first question. You were asking why we don't continue the typical benzyl benzoate for 10 days continuously. So the answer to that is that it can cause irritation. Okay, it can cause contact dermatitis. The benzyl benzoate can also cause contact dermatitis. So we want to minimize the possibility of that. That's why we have to pause for 3 days before continuing. And usually 3 days treatment is even enough to kill the adults mites. It's just that we want to make sure that we don't leave any stone unturned. That's why. And then you know that the eggs usually would hatch 3 days later. That's why we have to still do a repeat treatment. Otherwise, the first 3 days would have been enough. So that's the answer to the first question. The second question is, how do we distinguish the rashes in genital herpes, genital scabies from other genital lesions? Yes, there are different genital lesions that can occur. Like I said, the one is usually appears as a wheal. A wheal is like a localized swelling. Localized swelling that's usually around 0.5 meters to 1 centimeter in diameter, which usually go down within 4 hours. Okay, that's a wheal. That's what the rash looks like. Even rash is actually not a wheal because that particular swelling will not go down within 24 hours. The second possible differential could be genital herpes. Genital herpes, it could also appear like this, but it's mostly in form of a blister, in form of multiple blisters that are confluent together, and it's usually as opposed to the scabies rash is very itchy, but not particularly, not exactly. But in genital herpes, we have more of, which later on these blisters will become an ulcer. So history is very important, and then knowing the evolution of rashes is also important. Then there are other genital lesions like genital cysts. It's usually in the form of an ulcer. The person would just see a painless ulcer, you understand, and it's not usually itchy. So those are the things, those are some of the ways of knowing. And then there's also genital warts. Okay? Genital warts is usually made up of solid papules, which are very rough. They look very rough and velvety on the surface. So that's how to, these are the commonest lesions that can be seen in the genital area that can cause confusion with kids. I don't know if you have answered your question, yes.
Yes, thank you for the explanation. So we'll now give Dr. Akafa to respond to this question. What is the normal SpO2, especially in pregnancy?
Okay, thank you very much. The normal SpO2 is 95 to 100 in a patient that doesn't have any pathology. And even in pregnancy, it is like that. In pregnancy, we know that there are physiological changes so that the FRC, functional residual capacity, is reduced. And so many things, the growing pregnant uterus is pushing the test upward. But that does not affect the SpO2 reading. What it affects, you say there is a compensation of depth and rate of respiration to compensate for that pregnancy. That is why you see people, women, 8 months, 9 months, you see that they normally get tired, you know, they breathe with effort and all these things to compensate for that reduce in FRC. So in pregnancy and non-pregnant, SpO2 range 95 to 100. The second question said, what is the role of oximeter in carbon dioxide poisoning? Of course, we said that carbon monoxide and hemoglobin, oxyhemoglobin, they are the same. The oximeter cannot differentiate that. It means that you can't use the oximeter to diagnose carbon dioxide poisoning. What you can use is your history. And when you have a history of that, and I did say that you take blood for co-oximetry, where it's going to tell you the percentage of carbon monoxide in the blood, percentage of hemoglobin, the percentage of met hemoglobin, and others. So it is a pulse oximeter will not be able to diagnose diagnose a carbon dioxide poisoning. It only shows that a patient with carbon monoxide will give you normal oxygen. So thank you.
Okay. Thank you, Dr. Akafa, for the response. I've not seen any hand yet. I don't know if somebody still have 1 or 2 questions to ask. I've not seen any hand. I also want to acknowledge the chairman and the past chairman in our midst. Our chairman is on the call, Dr. Bako Isifanos. Our past chairman, Dr. Nkanta, Dr. Boyi Bawa. You are welcome. We are highly welcome on the call. We appreciate your presence. Any more questions? I've not seen any hand raised. Okay. In the absence of any hand, we want to appreciate everyone for joining this call. We will continue tomorrow, which will be physically at the doctor's house. And it will start from 9 a.m. in the morning. And there will be a link that will be sent for us to fill our details so that we can be able to fill and give people their CME certificate. So in the absence of any question, I want to call the chairman, Dr. Baku, for the closing remark. Over, sir. Dr. Baku. Chairman, sir. So, well, in the maybe chairman is maybe the network issue. So, want to appreciate everyone, our elders and colleagues, for joining us, and we wish us a nice day. We appreciate our presenters too for their time they took to give us this presentation. We actually appreciate you so much. We want to thank everybody. We wish us a nice day. Thank you. Bye.